Уважаеми колеги, след малко ще започнем лекцията. Някои от вас познават професор Дацерт, други не. Аз ще го представя накратко. Той е ръководител на клиниката по уши-нос-гърло в Бохум, Руски университет от много години. Много често е посещавал Стара Загора и е наш много добър приятел, освен всичко друго. Той ще изнесе цикъл от няколко лекции, 4 лекции, свързани с проблема за слуха. Сега ще е първата лекция от този цикъл. Надявам се другите лекции да имате възможност да бъдат и онлайн, така че да има и по-широка аудитория. I explain about our lecture initiative, and now is your talk about the first of them. Hearing quality is life quality. Please, Professor Dацерт.
Okay, thank you very much, Peter, for the nice introduction. I'm also very thankful for the warm welcome by Professor Yarkov. We just talked to him, and I'm very happy to be here, to see you all in the audience. Some of you I know already, I have known over the last years, and it's a great pleasure for me to be here today and to talk to you about the phenomenon of hearing. So, when we have planned and discussed these talks, we decided to prepare not only one talk, but a series of lectures. And today is the first lecture out of 4 presentations, which we plan to give over the next months, so let's say over the next year. And the headline of all these talks is hearing quality is life quality. And I hope at the end of my talks you will understand what I mean with it. So today I would like to speak about how hearing functions, how hearing works, and what is hearing for. Why do we need it? Why do we need 2 ears in the different stages of age of our life? And the next lesson or the next lecture will be about diseases that affect hearing loss and how we can treat it. Followed by a 3rd lecture talking about surgical options, microsurgical options for hearing reconstruction. And finally, maybe at the beginning of next year, I will speak about indications of implantable hearing devices and tell you what different devices are available, what are the indications dependent on the hearing loss. And I just learned by Professor Yarkov that healthcare and also digitalization is a main topic of research in this university. And so you may be interested to hear about it, and maybe you can also join some of these experiments and projects we are planning to do. So my name is, as mentioned already, Щефан Дацерт. I'm from the city of Bochum, which is in North Rhine-Westphalia. This is the state in Germany. This is Berlin to your orientation. And my university is the Ruhr University in Bochum. It's a relatively large university in the western part of Germany with more than 40,000 students. So it's a big university. And at this university, I'm the director and chair of the Department of Otolaryngology for a long time now. So this is since 2005. I was trained in Würzburg University with Jan Helms, my teacher and my mentor, and Petър Руев also know him. And I did a research fellowship with the DFG, the research support from the German government, in California, at the University of California in San Diego, doing some research about inner ear questions and inner ear research. After that, I performed my postdoctoral teaching qualification still in Würzburg by that. And from this time, I had contact to a number of colleagues from Bulgaria, including Petър Руев and Mario Milkov. And in the following years, we started a relation and a cooperation doing training courses for students and young doctors, in particular in microsurgery of the ear or in sinus surgery. And during my time as the president of the German ENT Society, my task also was to organize the German ENT meeting. Bulgaria was the invited guest country, and I was very happy to see how many colleagues from Bulgaria came to Berlin by then to join us. And I'm also a proud honorary member of the Bulgarian ENT Society. So our intention is to open this long-lasting relation to you and to young colleagues from the university and young doctors who are interested to join this relation and develop themselves into the area of otolaryngology. All right, so now you know who I am. We can start to talk about hearing and the hearing processes. So this is the first lecture, so to say, of the series, and these are my disclosures. They should not influence the educational assignment of the presentation. And let's start to talk about hearing. So as you know from your education, the sense of hearing is a very special, very sophisticated process. And it's interesting to talk about how our ears interact with the brain. So ear-brain interaction is very important, as you will see during my talk. And this finally opens us and allows us not only to listen, but to understand and to experience people and the world around us. And like our heart, our ears are constantly busy. They are always at work, all day long, all day over the night. And they somehow connect us to the world, even when we are sleeping. Our hearing is still active. And if any step of this complex and distinguished hearing process is interrupted, there is a risk of hearing loss. And hearing loss will separate us from the people and from the world. So, basically speaking, hearing is the process of sound traveling through the outer ear, the middle ear, the inner ear, and then to the brain. But although the ear is the sensory receptor organ for hearing, interpretation and processing is performed in the central auditory areas. Hearing is the first line to develop communication skills. This is an important knowledge. And we also know that babies inside the mother's womb during pregnancy already start to hear. And after birth, hearing is a very important precondition to develop speech. Otherwise, speech development is almost not possible. You have to use alternative tools to communicate. And in older people, I would also like to address this later on. Hearing loss may lead to cognitive deficits, may lead to social isolation and depression, and over the last years are increasing evidence that hearing loss also may contribute to the development of dementia. So let's look a little closer to the pathway of hearing. Important is that both ears are involved, and we will follow the sound waves through the external middle ear, internal ear, the cochlea, and then through the auditory nerves to the central auditory regions in the brain, and talk about that. So the outer ear, external sound waves enter the outer ear and meet the tympanic membrane, which starts to vibrate. And if you move your auricles, and if you enlarge your auricles with your hands, you realize your hearing will be immediately better, and also your directional hearing will improve. So this is part of the outer ear's task to prepare the sound, so to say, for the middle ear and the inner ear processing. Vibrations of the tympanic membrane will then be transferred to the ossicles, incus, malleus, incus, and stapes. And you know these are the smallest bones in our body. So if you want to do surgery on them, you need an operation microscope. Otherwise, it will be difficult to see the details. So they are very small, but very effective. And sound vibrations then travel through these ossicles to the stapes footplate, which is the oval window. You know there is an oval and round window. These are the connections between middle ear and inner ear. And this is also very important for sound transfer and information transfer to the inner ear. Inside the middle ear, the tympanic cavity should be filled with air, as shown here, and the pressure in the middle ear should equal the external atmospheric pressure. This is the best condition for the tympanic membrane and the ossicles to vibrate. And you can imagine if there is fluid behind the tympanic membrane, like in middle ear infection, otitis media, things like this, then the vibrations are reduced and the patient has a conductive hearing loss because of lack of vibrations. What is also interesting that the tympanic membrane is relatively large in its area compared to the stapes footplate. And therefore, the middle ear works as an amplifier, a passive amplifier, and we talk about sound pressure transformation. And the degree of amplification is 1 to 22, which is a lot. This equals about 27 decibel, and if it doesn't work, it gives a hearing loss. Then, next step, the footplate transmits the vibrations to the inner ear perilymphatic fluid. And this finally leads to a mechanical stimulation of the so-called hair cells, the receptor cells in the inner ear that are inside the organ of Corti. And you know that the cochlea and the vestibular organs form an anatomical and physiological unity, so they belong together somehow. And if we look at a cross-section of the cochlea, we find three compartments. Scala vestibuli and scala tympani are filled with perilymph, and the scala media is filled with endolymph. And the organ of Corti is associated with the scala media. When we look at the higher magnification, it sits on the basilar membrane, so the whole thing vibrates through the fluid vibrations. And the organ of Corti maintained 3 rows of outer hair cells and 1 row of inner hair cells. And these hair cells are covered by the tectorial membrane. Tectorial membrane. On top of the hair cells you find the sterocilia, the so-called hairs of the hair cells. That's why we call them hair cells. And these little sterocilia will be deflected, dislocated by the movement of the tectorial membrane, and this is the sign for the hair cell to work and to provide mechano-electrical transduction to the auditory nerve. And the frequency range of the cochlea in human beings is from 16 Hz up to 20,000 Hz. So it's a wide range. There are animals who have more, but for human beings it's a wide range, and we have to protect it and we have to preserve it because we need it. So if we look to this process of mechano-electrical transduction a little closer, we see here again the stapes footplate, and the vibrations go to the perilymph creating a so-called traveling wave. And these traveling waves are similar to waves on the beach. They go on their course, they form a maximum amplitude, and then they fall down. And every maximum amplitude belongs to a frequency. So every frequency we can hear has its own traveling wave. And at the point of the maximum, the outer hair cells, the stereocilia of the outer hair cells, will be deflected. And as you probably know, I go one picture back, the frequencies are located at different spots in the cochlea. The high frequencies are at the base of the cochlea, and the low frequencies are in the tip of the cochlea. So there is a tonotopic orientation inside the cochlea, and that's how frequency discrimination works. And when the outer hair cells are stimulated by deflecting the stereocilia, they start to contract. But it's not as easy as shown here, but this amplitude, this passive amplitude, is not enough to really stimulate the outer hair cells. And what happens is that if the stereocilia are moved away, ionic channels open, there is a potassium in-flight from the annulum into the outer hair cells, and they actively move, they contract. And this active movement leads to an amplification of the passive traveling wave to an active traveling wave. So the amplitude is sharpened and is amplified a lot, we have to say. The difference between passive and active amplitude is 50 dB. So that means if the outer hair cells are damaged by noise, by infection, by drugs, by whatever, you have a hearing loss of 50 dB, which is a lot actually. And by this active mechanism, the inner hair cells are stimulated, and they then give the information to the hearing nerve by releasing neurotransmitters. So a very specialized, very delicate process, and is vulnerable to several kinds of damages we will talk about later. And that's why we have to be careful with our ears. And then, as you probably know, and I talked already about it, the auditory nerve gives this information to the central auditory areas where their hearing is processed. All right, so now we know how the inner ear works. We can talk about what is hearing about and what is the task of hearing during the different ages of a human being. If we look at the time of pregnancy, we know that small babies start to hear relatively early. So at week 18, the baby is able to receive or to perceive the first sounds, and this development goes further till week 25, 26, when babies are able to respond to noises and to voices inside the mother's womb. So hearing develops as one of the first sensory organs in the human body, and about short after the half of the pregnancy, hearing provides perception of the mother's voice. Babies can listen to the mother's heartbeat, to the breathing, and all this contributes for the baby to feel safe, to feel protected. And it knows its surrounding, it feels well. And it is also known that babies at this age in the mother's body can perceive music. So there may be music that calms down the baby's mood, and there may be music that excites the baby's mood. So it's obviously important what kind of exposure is given to the baby in terms of hearing. So very early before birth, hearing is present, and hearing influences the baby's mental and physical development, so to say. Since we know that hearing is crucial and very important for speech development after birth. We have in Germany, and I hear you also have it in Bulgaria, newborn hearing screening. This is a testing method recording ultraacoustic emissions or auditory brain responses to detect whether the baby may have a congenital hearing loss. And if the newborn hearing screening is positive, so it means the baby didn't pass the test, then further investigations are necessary that may end in an early implant of the cochlear implants to get the babies the chance to hear. Because hearing deficits may cause learning problems. Learning problems may reduce the academic achievements of the children, of the young people. And they also may result in social withdrawal and in a poor self-awareness. And this only because hearing doesn't work. So it seems to be a relatively simple cause with a wide following, with a bad social development for the patients. And also, hearing deficits may have an impact on professional choices, as you can imagine. From a study from the US, we know that lifetime earnings for people with untreated hearing loss are known to be 30 to 50% less compared to normal hearing people. So if we don't identify hearing loss very early and help the children and the young people, it may have a reaction for the rest of their life. So it may influence their whole life. That's why it is so important. If you look at this picture, you see a happy face. And everybody thinks, well, how nice. This little boy likes his music. But if you look in detail, you see that this kid is wearing headphones. And this is a tendency we see in Europe and we also see in the US, that younger people and also young children like to wear headphones. And what they also like, to turn up the loudness of the music or the story they listen to. And they also like to do it over hours, every day. So he looks happy, but there is still the potential risk of noise damage to his ears. And we have to be aware of this. And the reason why children are more vulnerable to noise damage is that their auditory system is still in development. So there are still formations that have to be built, and the network is not complete in the brain and so on. So there are more areas where noise can damage and can deteriorate the hearing. And also the ear canals of kids are smaller, intensifying the perceived sound levels when they come to the ear. And the headphones also, they close the ear up, so the sounds cannot go away. They go directly to the tympanic membrane, as explained before. So we should be aware how long and how loud kids listen with headphones to their music. And it is also important to know the early signs of hearing loss in children. If they ask for repetition, if they complain about tinnitus in their ears, if they're speaking relatively loud, you talk to them and they cry, or they don't react to loud noises when you call them and you cry to them, then you have to be suspicious and provide a hearing test and see what is necessary. And in terms of headphones, have you heard of the 60-60 rule? This is a relatively simple recommendation and will help a lot. Children should be limited to no more than 60 minutes of audio devices a day at no more than 60% of the maximum volume the device is able to provide. So if you try to give this rule to your children and to friends and to your patients, it may help that the ears don't get a noise damage at an early stage. Let's talk about hearing with 2 ears. Do we really need 2 ears? Maybe one is good enough for hearing and for communicating. You can test this relatively easy by yourself. When you go out tonight with your friends, plug one of your ears only for an hour. And then you will see how miserable life will be for you during that hour. Because binaural hearing not only provides directional and spatial hearing, but it also helps us to identify speech in a noisy area, like shown here. If you sit together with people, with family, with friends, everybody is talking and you have only one ear available, you will not understand a word. So both ears are essential and they are a central part of everyday listening. And also, directional hearing is important in terms of perceiving danger signals. You know, in traffic, for instance, when a car is coming from the back and you don't know it's coming from the right or from the left, to what side should you jump to get away from the car? So this is also necessary, but in particular, speech discrimination and noise is dependent on 2 hearing ears. So always persuade your patients to wear 2 hearing aids, 2 cochlear implants if necessary. So we definitely, absolutely need 2 ears for everyday life. When we talk about adult and elderly people in terms of hearing, we know that hearing is the precondition of verbal communication, stay in touch with family, friends, and also during profession. So hearing promotes social integration, prevents from isolation and depression, stimulates cognitive processes, and, which is very important, stimulates quality of life. And to prove these statements, I would like to report to you about a study that was performed in our department by Professor Christiane Völter and his team together with us. And it's about the relation between hearing and cognition, cognitive processes, in particular in an older population. And therefore, I have some more information. For the next years, till 2050, we expect that 2 billion people worldwide will be older than 60 years. So this is more than 20% of the population. This is worldwide, but this is the situation we have in Europe today already. So in Germany, this is exactly the older population we have nowadays already. So aging population is growing worldwide. This is an important statement by data from the United Nations. We also know from WHO information and from our experience, of course, that prevalence of hearing loss rises with age. So if people get older, we get more cases of hearing loss. Because 30% of all people above 65 years and 55% of all above 80 suffer from a disabling hearing impairment. So if you count all these people, it's a huge number of patients that need treatment. And from a longitudinal study by Frank Lin and his group with more than many thousand patients, we know that human beings with a moderate hearing loss double the risk to suffer later on from dementia, and we know that patients or people with a severe hearing loss have a 5-fold risk. So if you go up here, it's a 5-fold risk to suffer from the dementia when they are older. So this is a really relevant data which should make us aware. And the question that arises from this data is, if hearing loss provokes development of dementia or deterioration of cognitive processes, are we able to stop this cognitive deficits by hearing rehabilitation. So we have been looking to a group of older cochlear implant patients in our department. You probably know that a cochlear implant is an electronic hearing device where an electrode is surgically placed inside the cochlea and directly stimulates the auditory nerve, because the inner ear is damaged. The hair cells are dead, are mostly dead in these patients. They don't hear with the inner ear, so they can receive a cochlear implant and have a chance to hear again, so to say. Talking about cognitive processes, there is a differentiation between two kinds of intelligence. We are neurophysiologists, psychologists, differentiate between crystalline intelligence. This is what the brain collects on information over the life. And this information, or this crystalline intelligence, usually remains stable when you get older. The other part of intelligence is the fluid intelligence, which represents the flexibility of your brain. And this includes processes like working memory, inhibition, attention, processing speed. This is fluid intelligence declines with age. So the highest point, or the best fluid intelligence, is between 20 and 30 years. And when you are older than 30, it declines already. So don't look at me, I'm old. No more fluid intelligence. But life still works for me. And so we have looking in this study for different cognitive subdomains, such as inhibition, long-term memory, processing speed, working memory, short-term memory, and attention. And these are the cognitive tests associated with these cognitive subdomains. And we developed a cognitive test battery together with the Institute of Work, Learning and Aging from our university. It's a computer-based test system which is even accessible for older patients. So you see this 73-year-old lady doing the test, and the test is pretty easy. So you have, for instance, in the flanker test, you have to find out all the spots where the little triangles show to the right side. Or the patient has to do easy calculations. Or he has to find all the W's with 2 dots on top. And so these tests are associated to the different cognitive domains. And while they do it on the computer collects or evaluates how fast they do the test and how good they do it. And from these data, they calculate a so-called inverse efficiency, which is directly shown after the test. The test takes about 30 to 40 minutes, so not too long. And the patient is the better, the lower the bar is. So if he reaches low bars in this area, these are good cognitive results. So what we have done, we have given this test to the patients prior to cochlear implantation, half a year after cochlear implantation, and 1 year after cochlear implantation. And this is what you see. Black is before implantation, gray is half a year, 6 months after implantation, and the dark gray is a year after implantation. And you remember, the lower the bar, the better the result. After 12 months, in many of these domains, we saw a significant improvement of cognitive abilities in these patients, which was very promising, actually. We also looked to the quality of life using a special questionnaire, the Nijmegen Cochlear Implant Questionnaire. And here, of course, the results are better when the bars are high. So we were looking to domains such as basic sound perception, speech production, advanced sound perception, self-esteem, very important, activity limitations, and social interactions. And in all these domains, the patient voted for a better result, which was a very good result, and we were very happy about this. So in terms of elderly patients, we can state that cochlear implantation gives not only a significant increase of hearing and a better communication for these patients, but also stimulates their neurocognitive abilities and improves their quality of life. This is what we all want to have. Quality of life should be the aim of all our trials, all our medical treatment, and that is very important. So the question that arises is, can we influence the development of cognitive deficits and even dementia by hearing rehabilitation? And there is an interesting investigation which is published by Livingston et al. He is from the Lancet Commission of Dementia. So Lancet, you know, a very famous, very valuable scientific journal. And here we see different modifiable and non-modifiable aspects that support dementia. And we look to the modifiable aspects. We see, I don't know whether you can read it, this is hearing loss in midlife. So hearing loss in midlife means that the patient has an 8% higher risk to develop dementia when he is older. This is a lot, I think. And it's worthwhile to identify hearing loss in the 50s. So we are discussing in our society now whether it's worthwhile to also do a hearing screening, not only for the babies, but also for people in the 50s, to early detect a hearing loss, to treat it, and hopefully prevent cognitive deficits, maybe have a positive aspect not to develop dementia. So I'm coming to an end for today, and I hope I was able to tell you a little bit and convince you that good and binaural hearing does not only mean to be able to listen to sounds, but that it provides speech understanding and gives you the chance of a good communication with your surrounding. That good hearing contributes to mental integrity, mood control, prevents from depression and so on. Physical integrity in terms of balance control, directional, spatial hearing also gives you security when you move, when you walk, when you jump and so on during sports. Binaural hearing is important to react to alarm sounds. And binaural hearing also is important to listen to music. And overall we can state a good bilateral hearing is crucial for a good participation in social life. And so my take-home message today is take care of your ears, take care of your patient's ears, and always keep in mind hearing quality is life quality. And so let's work together for our patients to preserve hearing and to make them happy people. Thank you very much for your attention. So if you have questions, I'm more than happy to answer, if I can. Or discussions. Everybody seems to be happy at the moment. You can also come later to me and ask me if you don't like the public discussion. Okay, so again, thank you very much for coming, for your time, for listening. And in a few months, we would like to present to you the next talk, and I would be more than happy to see you again by then. So, have a nice weekend, and thanks for coming. You're right. But, compared to the whole of